Hi everyone, my name is Andy Bailey. I'm the Virtual Ward Operations Manager at Cambridge University Hospital. So where people were deciding whether it should be called a virtual ward or a hospital at home, we decided to call as CUH Virtual Ward at Home to combine the two. So I'm going to talk to you a little bit about how we set up our virtual ward, the challenges we faced when setting it up, a little bit about the digital tech that we use, how we sort of have shown the realisation of the virtual ward and the benefits, and our next steps and how we're looking to progress. So Cambridge University Hospitals is a big acute hospital. It's one of the Shelford Group. It's a big teaching hospital. It's got roughly about 1,000 beds, about 50 to 55 ITU stroke neurocritical care beds. It's got a big ED with a major trauma centre that sees about 400 or so patients a day. And it serves Cambridge, which is a population of about 150,000, but also wider Cambridgeshire, which is roughly about 650,000. And the other important point about Cambridge University Hospitals is we're also a tertiary service, so we see a lot of patients that come from outside of area come to receive those services at Cambridge. So, big hospital, and we had the challenge of when NHS England said how to set up a virtual ward, you know, what to do next. We had the big task of going in that direction. So we wanted to set up a inclusive virtual ward that was available and could be accessed by all, and we could put at scale. I just want to show you a video. I don't know if that's possible. Yep. Just click. This is our virtual ward.
The CUH Virtual Ward at Home allows patients to get hospital-level care at home safely and in familiar surroundings, helping speed up their recovery while freeing up hospital beds for patients that need them most. Just as in hospital, patients on a CUH Virtual Ward at Home are cared for by a multidisciplinary team who can provide a range of tests and treatments. If a doctor thinks that you're well enough to be managed at home, they can refer you to the CUH Virtual Ward at Home. They do this by contacting the Virtual Ward team to discuss your treatment plan. The Virtual Ward nursing team will do the final checks and discuss with you what will happen. This may involve being remotely monitored and have regular contact with the Virtual Ward nursing team. The Virtual Ward nursing team may come to your home depending on your circumstances, or we arrange for you to come to hospital. We will then give you your virtual ward equipment and show you how to set it up. Once you're set up, the virtual ward team will be able to monitor your heart rate, oxygen levels, respiratory rate, blood pressure and skin temperature while you're at home. Whilst you are on the CUH Virtual Ward at Home, we will monitor you regularly, and every day a ward round will happen in the same way it happens on a physical ward. This is where we review your plan, treatments and medications. We will also review to see whether you're suitable to be discharged or need a little bit more time to be monitored or recover. If there is a problem whilst you're on the virtual ward with your health, we may arrange for you to come in, and in an emergency we can call an ambulance. Once you're discharged, a summary of your CUH virtual ward care will be sent to your GP. This will update your GP of your care whilst on the CUH Virtual Ward at Home. Once you're discharged, the Virtual Ward nursing team will then be in touch with you to arrange a collection of any equipment we have loaned to you, or a suitable time for you to bring it back to the hospital. It's important that we get this back so we can prepare it for our next patient on the CUH Virtual Ward at Home.
It does make me happy to see all those smiley faces. We wanted to set up a virtual ward, we wanted to do it at scale, we wanted to be inclusive, and we wanted the ability to be able to detect if a patient was deteriorating rapidly while they were at home. And we did this we set up a core planning group that was led by a medical exec director, and we brought in all the stakeholders across the hospital. So that included IT, telephony, patients, all the different specialties, the community services, literally everyone we could think of that would have a stake in how a virtual ward would run at CUH. We brought them together and discussed what was our ambition, what did we want to achieve by setting up this virtual ward. Now, at the time, and still to now, the pressures on the hospital around capacity were significant. We had long waiting lists to get through. So we aimed at doing the step-down model. Now, Niall spoke about a step-up and a step-down model. Our focus was, let's see if we can alleviate some of the pressure on our capacity. What would happen if we took out 1 or 2 days length of stay for every single patient that came to this hospital for treatment, or as many as possible? We would really alleviate some of those capacity pressures. So that was our focus, and that was our dream that we set off, and we did this by setting up the core planning group. Now, come November the 1st, November 2022, we got our first patient. You might think they might have come from a standard core ward somewhere, from medicine perhaps, but no, we got our first one from ITU. So that set the ambition straight away that we're not there to act as some sort of safety netting service. We were looking to take care of sick patients. So what can our virtual ward offer? Well, what we were looking to do was mirror essentially what happens in a normal hospital bed as much as we could as possible. So we brought in continuous and intermittent monitoring, which I'll talk to about the tech in a minute, blood tests, imaging slots. So our patients are treated in exactly the same way in terms of priority for access to imaging, wound care, pain assessments, management, fluid input and output monitoring, well-being symptom checking, IV therapies, medication reviews, and much, much more. We're not stopping there. We've grown and grown, and the beauty of what's happening in a moment across the whole sort of virtual ward community is different trusts are doing different things all of the time, and we're learning from each other. So we're growing exponentially. So the aim was to, mirror what we could do in a normal hospital bed. So how does a patient get from a ward bed onto a virtual ward bed or a virtual ward at home? So there's essentially 2 different ways that a patient can get referred to us. The first way is we set up meetings with all the different specialties across the hospital, and we created pathways. And the best example I can think of around this is one of our orthopedic knee replacement surgery pathway, where patients who normally underwent that surgery would stay in hospital 1 or 2 days after that surgery, just to check that they hadn't got sepsis before they went home. With us now, the direct pathway is anyone that comes in under that pathway will come directly to the virtual ward the moment after they've had their surgery and a physio says that they can mobilise and go home. They'll come straight on to us. We'll monitor them for a couple of days using the remote digital technology and discharge them when they're good and ready. So that's a set pathway, and we've got pathways like that with multiple specialties right across the hospital. That's one way of getting a patient onto the virtual ward. The other way is a bit more of a free-for-all, and we've built relationships with all the medics across the hospital, and when they're doing their ward rounds or their board rounds, they are able to identify patients that they think, actually, what are they waiting in hospital for? Is it actually they're just waiting for their imaging slot, then we'll review the results and then we might discharge? Or is it what they're waiting for? Can they wait at home? And we built that relationship with lots of the medical staff across the hospital. So there's a general referral pathway, and that's grown exponentially. And I'll show you the data on that as we go through. So when we get the referral, we'll then send out a nurse to go and see that patient. We'll give them an introduction of the virtual ward. We might show them that video, for example. We'll get them to consent to come onto the ward. We'll show them the technology and how it works. We'll link them up with all the technology. We'll talk about plans around how they get the investigations. And then we'll communicate with the rest of the ward and the clinical teams about what the next steps are, how long they're expected to stay on the virtual ward, what it is we're going to be doing for them on the virtual ward, and what does discharge look like for those patients. So the tech that Noel explained a bit earlier, we also use Masimo technology and have been from the outset. They also work in theatres, ITU, and also our surgical hub as well, right across the board. So we have a good relationship with them, and we have the wearables that you can see in this picture there. Now, one of the things I was always curious about when I first started this role was how will all patients get on with using this tech? Because it's not always that straightforward, and not everyone is Superman on or Superwoman on using a mobile phone, etc. I've got a 78-year-old dad who trying to explain how to use a mobile can be some challenging sometimes, and he's a man who, so he tells me, knows everything. But the feedback we have had has been pretty amazing. We've had very little issues with the technology at all. We have a really good relationship with Masimo. We meet with them on a monthly basis. We talk through any concerns. And the patient feedback, we've done multiple sort of surveys and forums, and really the tech has not been a factor in this project. It's been really, really good to see. And when we have had a patient that struggled with using the technology, we've been able to remotely dial in or do a video call with them in order to fix or find a solution or whatever's needed. So this is what our dashboard looks like. So the tech works in a way that, like Noel explained, which it connects to a mobile phone through Bluetooth, and then that's linked onto our dashboard, and we have a nurse that's looking at the dashboard 24 hours a day to check the vitals that are on track. Now, when at the point of onboarding, we'll talk to the patient, we'll talk to the patient's doctor about whether that patient needs intermittent monitoring or whether they need to be on continuous monitoring. And we'll talk through how that all works and how to onboard a patient, etc. This is a picture of what some of our wearables look like. So one of the big things when we set up the virtual ward, and I think most virtual wards have probably suffered with this challenge, is around the building of confidence. When we spoke about this project across CUH, there was a real sort of divide in the camp. We had a group of clinicians saying this is amazing, this is the best thing since sliced bread, it's exactly what the NHS needs, we need to expand this rapidly. But then on the other side was the far more, I'm not sure this is going to work, it doesn't feel safe to me, I feel like I'm going to be looking after more patients, how are we going to manage this, there's no money in the system, we can't scale this, or this is going to be the safety netting service for CUH. And there was a real divide in that camp. And when we first set out, we had a target of hitting 45 virtual ward beds by the summer. So we launched in November 2022, and by June 2023, we wanted to have an occupancy of about 45 patients on a virtual ward. That was the goal. But if you look at our data, and I'm going to show you this in a short while, that actually for the first 4 months, we had barely 10 patients on the virtual ward. And that wasn't because we didn't have the ambition, that's purely we just weren't getting the referrals. And what we did as a result of that is we did, and this is our team, we did lots and lots of work around the comm strategy. And we're still doing it now, every single day. Any opportunity there is to celebrate something that's going on our ward, we're doing it. We are talking with the clinical teams every single day. We're going to the board rounds every single day. But the biggest thing that's had the impact on the scaling the numbers up is actually by pulling the patient experience data. And at that point, about 4 or 5 months into the virtual ward running, we were getting that data back in abundance. We were able to share those patient stories with all those clinicians that had referred. This is what happened to your patient while they were on the virtual ward. This is the outcome of that patient. And this is what they've said about it. And that led to more and more referrals. And I'm going to show you this now. So I went to a conference. I was on a conference where we talked about having the idea of having impact dashboard to be able to show the hospital that that you're making an impact to to our patients. So as you can see, this is our occupancy, and this is for the first 4 months, completely flatlined. This is the point we started getting some really, really good patient data back and started sharing with the teams. And you can see we just exponentially just grew from that point onwards. Now, we don't have the staff to go much above that, although we've tried. We've flatlined now, but we're sitting at roughly 70 to 80 patients, so almost double what our target was within less than 9 to 10 months of running. And most of that was down to the patient experience and the stories that we were sharing with clinicians across the hospital. Now you can see, just here, we've started to taper off slightly. And the reason that's happened is because we've done a really big focus over the last 8 weeks on our length of stay. And we have driven CFDs and criteria to reside across the ward to really, really show that the patients that are on our virtual ward are there, A, for not long periods of time, they're there because they need to be. And at the point that we think they are suitable to be discharged from the hospital or from a hospital bed, it really should be similar to discharge from a virtual ward bed. This is our dashboard, so we share this across the trust on a monthly basis. It goes on to the core planning group, it goes to the execs, gets talked about in bed meetings. Any opportunity there is to share the impact the virtual ward is having on the hospital, we literally we pulled this out. So one of the things that we monitor is the news scores. So we look at the news scores of the patients coming onto the virtual ward at the time they come on, and we compare them with 2 of our medical short stay units in the hospital, just to try and get over some of that rhetoric around it being a safety netting service. We're actually showing that actually the news scores of some of the patients are very similar to what you would get in a medical short stay unit. So this is just one aspect of how we're trying to prove that. And I can see across multiple trusts, lots of hospitals are trying to do that in different ways, but this is just one of the ones that we're doing. Bed saving days, I'm going to talk a little bit about that in a minute, and patient experience, I'm going to talk a little bit about in a minute. This is our average length of stay, which is currently sitting at about 10 days. There are patients that do go over that, but our average is about 10 days. And if I pulled this data along further, you would probably see it started to taper off slightly as well now, given the work we've done around CFDs. Now, one of the big things that CUH are driving at the moment is morning discharges, because of taking the impact away from emergency departments. So the quicker we get people out of hospital earlier in the day means we can release some of the capacity pressure that happens in an emergency department, gives them the ability to not bottleneck. So one of the things we monitor is their referral time, so the point a patient is referred to how quickly they're admitted onto the virtual ward. So we're averaging about 5 hours in general. And we're doing lots and lots of work to try and reduce that down. There are lots of variables involved in this. For example, transport is a key reason that we can't get patients out earlier. But we are trying to really bring down the time from the moment that referral hits our inbox, that we're there ready to onboard the patient and we've got all the details that we need. And we've set that patient up ready to go home. And then this last graph here is our readmission data. This is patients that are discharged after 30 days of being on the virtual ward. So we're averaging around about the 6% mark of patients are readmitted after 30 days of being on the virtual ward. That is readmitted back into CUH, and that is readmitted under the same condition. But the general hospital, for the whole hospital, is roughly about 12%, so we're sitting about half that. We do also monitor in the background the number of patients when they're on the virtual ward, because we do have patients that we bring back in. What percentage of those are going in via A&E? And now I used to be the A&E operations manager, so it's a big no-no for me in terms of bringing people back unless they absolutely need to via A&E. So we're less than 2% of patients that are coming in via A&E. So, like I said, we're a step-down service. I think what makes us a little bit unique at the moment, lots of trusts are doing this now, is that we didn't set out just to do frailty, respiratory, and heart failure. We actually opened this up to all specialties right across the hospital. So our hospital is split into different divisions, A, B, C, and D. We also have a fifth division, Division E, which is women's and children, which we haven't got the referrals through for yet. But you can see here, Division A, which is mainly surgery and orthopedics, are utilising, this is the last 2 months' worth of data, utilising the virtual ward well. A lot, especially orthopedics at the moment, are really growing their service. Division B is a really small division, mainly oncology and haematology, and a little bit of urology as well. Although it's small numbers, the actual impact of those patients is really quite significant. They only have a small number of beds, but for example, we've set up a haematology pathway where patients go home with elastic merit pumps and an IV treatment, and they sit on the virtual ward. And this is the two services working together to get those patients out of hospital. Now, those patients would be in a hospital bed for at least roughly about 6 days. So we get 2 of them on average a week, which is a significant bed saving for that specialty. Division C is where a lot of our medical and DME. You can see DME, our frailty service, by far use the virtual ward more than any other service. They're almost 3 times the amount. And then ED and MAU, medical assessment unit, are not that far behind. And general medicine is roughly averaging about 20 patients a month. That's a little bit less because hopefully a lot of these patients, their medical patients, are coming via the MAU. And then Division E is lots of different specialties, including cardiology, ENT, endocrine, vascular, and those sort of areas. The only specialty I can think of across the hospital for adults that's not referred to us is stroke at the moment, and we're rapidly working up a pathway with them at the moment. So that's our dashboard, and that goes out on a monthly basis. I'm hoping that hasn't bored you with data. So we talked a bit about benefits. So hospitals, it seems, there's lots of different theories on how to measure bed-saving days, and everyone's doing it slightly differently at the moment, but this is sort of how we're monitoring it. So we look at the ICD diagnosis codes of the patients. So we compare in the same 5-year age band the diagnosis code of the patient coming onto the virtual ward and compare that to a patient that actually stays in a hospital bed. So you can see that on average we're saving around about 600 to 700 beds per month, bed days per month. There's lots of people at the moment looking at how to evaluate the financial savings, show its value for money, and all of that. I'm not going to go too much into that, but it's really clear for us, and this is just really just an example of, a patient 4 days on a normal inpatient bed, somewhere between 250 to 350 pounds per night on average, whereas actually if you can remove some of that stay and put them on a virtual ward, which is somewhere between 80 and 100 pounds per night, the savings are obvious of how it will affect a hospital in terms of value for money. Then if you actually replace some of that and put in an elective procedure in there as well, you can see how it all stacks up. And I'm 100% certain there'll be more and more evidence come out around this over the coming months. So this is the best bit of my job, is the patient experience. And like Niall said, we're sitting 96 to 98% a positive patient score most of the time. It's really, really brilliant to see. Not another service in Cambridge University Hospitals gets patient experience feedback like this. We do lots of surveys with our team. We're actually doing a piece of work with Sheffield University at the moment, looking at patient experience further depth. And we've had some real big wins in terms of some of the patient stories. We got a patient home for their 60th wedding anniversary on the virtual ward, or a new mum that was unfortunately unwell but had a new baby at home that we got home on the virtual ward, and similarly for a patient who wanted to get home for their daughter's wedding. We managed to happen. So the patient experience has been absolutely brilliant. Since running this ward, we've been going 18 months. I've not had one single complaint from a single patient, not a documented complaint by anyone. When I worked in ED, on an average month, I'd have somewhere between 50 and 20 complaints a month. It's really, really good to see. And not just the positive patient experience, but also we've had examples of where we've had a patient at home and we've had them on the technology and we were monitoring them. We were able to actually see that patient was sick before they even realised they were sick. They spiked a temperature. We brought that patient in. They had sepsis and were in ITU shortly afterwards. But had we not had that sort of continuous monitoring that was being observed at the time, that story may have been very different. So brilliant patient feedback. So where we got to, so I think about 2,500 patients now since opening the ward. You can see on this is the number of admissions per month. It's gone up exponentially over the months. In July, we had 168 admissions to the virtual ward, which was the most we've ever had. And it's summer. I wonder what it's going to be like in winter. We've built a fully functioning ward using the digital monitoring tech. We've got a nursing team, a pharmacy team, a medical cover. We've developed over 30 different pathways with different specialties. We've increased our occupancy over time, despite not having a full funding position. We've now got to a position where the tech, our digital monitoring tech, is now automatically syncing into our patient records. So what's coming through on the patient dashboard is going straight into the patient's record. So even if you're not actually on the virtual ward, but you do have oversight of that patient, you can see what their vitals are at any point. And we've recently won the HSJ award for improving out-of-hospital care through digital. I can't say what a significant impact the virtual ward has had on the hospital, but I can say a few different things. Number one, I've been at CUH for 10 years, and in that 10 years, every single winter, we've opened up a winter ward. Last winter was the first year that we didn't open up a winter ward. Now, I'm not saying that was 100% due to our virtual ward, but I know we made an impact there. I know we made a difference. And I also know that I meet with operations managers right across the hospital all of the time, and they are under a significant pressure to reduce the length of stay in their specialties all of the time. What I can say is every single meeting I go on to talk about length of stay, they are always saying their plan to reduce length of stay in their specialty is to use the virtual ward more. They're all saying that, which is a very, very different story to the one we had at the start. So a big success. So where are we going next? So we haven't done that third circle, which Niall spoke about. We've got the ED part right, we've got the step down part, and we're now just talking to a couple of different care homes about how we could set up pathways directly to our virtual ward. They are really keen to get going, so I don't think this is going to be too much of an issue to get set up over the next few months. We are rapidly pulling together a children's virtual ward, which we think will be live in October. And then on top of that, we have our neighbours, Royal Papworth, which is a heart and lung specialist hospital, which is only a stone's throw away from us, who we sort of collaborated with and said, what's the point in starting 2 virtual wards? We may as well pool resources together. And actually, from October, they'll be sending their patients onto our virtual ward, so we'll be working together. And then lastly, we have ambitions to get to that 120-bed mark. and that will be done through continuing to work with that step-down care, but also starting that emission avoidance work that we need to do. And that's it. Thank you very much.